Hello and welcome to Learn OBGYN. This is Amir, and in this video we'll be talking about third trimester bleeding and abnormal placentation. Let's start off by discussing a differential. The majority of this lecture will focus on these four sources of bleeding because they're abnormal and very testable, but a lot of bleeding you'll see in third trimester, especially at term, can be benign. What I'm talking about is bloody show. Bloody show is a scant bloody discharge, usually mucousy, that occurs either with early labor, so contractions and some cervical change, or after rupture of membranes. There are also some non-obstetric causes that you should keep in your differential. These include bleeding either from the cervix, vagina, or rectum. In particular, cervicitis or some sort of cervical infection such as gonorrhea or chlamydia, a cervical polyp, which is just a benign mass on the cervix. You can have a vaginal laceration from intercourse, cervical cancer, and rectal hemorrhoids. Most of these can be easily seen or diagnosed on speculum exam. But the four conditions we're really going to go into detail in this lecture are placental abruption, which is the most common cause of abnormal bleeding in the third trimester, placenta previa, which is the second most common cause, and also rare but not uncommon, Vasa previa and uterine rupture. Before we go on into more detail about each individual condition, let me give you a general overview on how to do the initial evaluation and general management for all of these conditions. First of all, you want to make sure the mom and fetus are stable with vital signs. So for maternal, blood pressure, heart rate, you could check orthostatics if you're concerned. And for the fetus, you could put them on external monitoring to measure the fetal heart rate, or at the bare minimum, get a fetal doptone to make sure that the heart rate is in the normal range. If there is only a scant amount of bleeding, you don't have to worry about this, but if there's a significant hemorrhage, then you have to initially begin with maternal resuscitation. Remember your ABCs. Make sure you have large bore IV access, 2 of them, give an IV fluid bolus, and get blood products ready. For physical exam, you always want to go from least invasive to more invasive, so start off with the abdominal exam. You are looking for 3 things on your abdominal exam. That's uterine tenderness, if there's any palpable contractions, or if the uterus is hypertonic or continuously contracting. And then you also want to do an abdominal ultrasound. The most important thing to evaluate is the placenta. You want to know where the placenta is located. In particular, you want to know if it's close to the cervix, which would make you suspicious for a placenta previa. Or if you see that it's close to the fundus or top of the uterus, then that could help remove that diagnosis from your differential. You also want to see if there's any bleeding behind the placenta, which would make you suspicious for a placental abruption. The other things you want to evaluate is the fetal presentation. You want to check to see if the fetus is vertex or cephalic, or in other words, head down, to see if a vaginal delivery is possible. And if indicated, you can also measure the amniotic fluid index or maximum vertical pocket to evaluate for possible rupture of membranes. The next thing you want to do is a sterile speculum exam, or SSE. On the speculum exam, you're looking to see if there's active bleeding or if there's old bleeding. If there's bleeding from the cervix or someplace else like a polyp, a laceration, or one of those other benign causes we discussed. You could also visualize to see if the cervix is dilated or if the patient broke their water. And then the next thing, and this one is really important to keep note of, a sterile vaginal exam. So this is useful to see if the patient is dilated. But you can only do this, especially in the setting of bleeding, if you know for sure that there is no placenta previa. If someone has a previa and you do a digital exam and you poke that placenta, you will cause a huge hemorrhage that's threatening for both the mom and the fetus. Fortunately, a majority of placenta previas are diagnosed on anatomic ultrasound, which is typically done around 20 weeks. So usually we aren't caught off guard by an undiagnosed previa. But you can imagine a scenario where someone was not getting any prenatal care and has had no anatomic ultrasound or any ultrasounds at all until they presented with vaginal bleeding. So in those patients, you would never want to do a digital exam on potentially disrupting the placenta if you do not know for sure that they do not have a previa. A speculum exam is okay because that's not directly hitting the placenta, but a digital exam where you try to measure how dilated they are should never be done if you don't know 100% that the patient does not have a previa. And then in terms of labs, we want to get a CBC to make sure the patient's not anemic. A type and screen has 2 purposes. One is for maternal if you want to give them blood, and the other is more of a fetal issue. If they're Rh negative, then you should give them Rhogam. Gonorrhea and chlamydia to evaluate if bleeding is from cervicitis. And if there's significant bleeding and you're concerned for DIC, you could look at PTT, PT, fibrinogen, and a D-dimer. You don't always have to get all these labs, especially these last three, but if there's significant bleeding, then you should add these on to make sure that your patient is not in DIC. And in terms of management, the general principle is the same for all these conditions. It depends if they're preterm or term. So if someone is preterm and stable, then you can observe for a while to see if the bleeding will self-resolve. And depending on how preterm they are, you may also consider giving them magnesium to help reduce the risk of cerebral palsy, or steroids to reduce the risk of respiratory distress syndrome. For more information on magnesium, steroids, and management of preterm deliveries, please check out my video on preterm labor and PPROM. If they're unstable, even if they're term or preterm, the management is maternal resuscitation, so make sure mom is okay first, and then delivery. Usually because this is an urgent delivery, it's typically done by C-section. If the patient is term and stable, you can consider inducing them via vaginal delivery as long as it's not contraindicated. However, oftentimes the condition itself that's causing the bleeding could be a contraindication to a vaginal delivery. And there could also be other contraindications, for example, breech presentation. If mom or fetus is unstable, even if they're term, it's always resuscitation of mom first, then delivery. And keep in mind, if the patient is Rh negative, then you should give them a dose of Rhogam to prevent Rh alloimmunization. So if someone presents with vaginal bleeding, sometimes it's useful to help differentiate whether that bleeding is from a maternal source or a fetal source. There are 3 tests you could use, but the main test we use nowadays is a Kleihauer-Betke test. Don't really waste your time memorizing these tests, I just include them here for sake of completion. So in the Kleihauer-Betke test, maternal serum, so this is blood from the arm and not vaginal blood, is taken and exposed to an acidic solution. In that low pH, hemoglobin A becomes soluble and leaves the red blood cells. Because hemoglobin A is leaving, the maternal red blood cells become pale or ghost cells. Fetal red blood cells, which have hemoglobin F, stay pink. So this is used to determine if there's fetal blood in maternal circulation, and it's useful for determining how much blood, because after vaginal bleeding, or if the patient is postpartum, this is used to determine how much Rhogam is needed to prevent Rh alloimmunization. Here's an example of what a Kleihauer-Betke test actually looks like. You'll see these pale cells here. These are all the maternal cells that the hemoglobin A has eluded from. And every once in a while you'll see a dark red cell, and these are the fetal cells that stay red or pink because they still have their hemoglobin F. Before we talk about the individual conditions, let's quickly review the anatomy of the placenta and the uterus. So this drawing over here is a cross-sectional figure of where the placenta and the uterus interact. Going from inside to outside, the first thing we see is the placenta. And then you have the decidua basalis. This is the endometrial tissue that has changed during pregnancy to support the placenta. Then you have the myometrial layer, and this is the thick muscle of the uterus that's responsible for the contractions. And on the very outer edge, you have the serosa, which is part of the peritoneum, or a thin epithelial layer that surrounds the outside of the uterus. Now let's go into individual conditions, starting off with placental abruption. A placental abruption is detachment of the placenta prior to delivery of the fetus. Remember, it's normal for the placenta to detach, but after the fetus delivers. For abruption, the placenta detaches earlier than it should, oftentimes even before labor starts. In particular, what's happening, there's a rupture of the vessels in the decidua basalis. Remember, this is the endometrial layer between the placenta and the myometrium. Out of all the causes of abnormal third trimester bleeding, this is the most common and accounts for about 30% of third trimester bleeding. You don't have to remember that's 30%, just remember placental abruption is the most common cause of abnormal third trimester bleeding. Now let's review risk factors. Like with almost everything in OB, a history of prior condition is a risk factor for that condition. So for abruption, if a patient has had a history of placental abruption in the past, they're at increased risk of having abruption again. The other things include abdominal trauma, most typically from a car accident. The rapid acceleration and deceleration affects the myometrial lining of the uterus and the placenta differently, leading to a shearing differential, causing the uterus to sometimes abrupt or tear off from the lining. Cocaine is a common cause of abruption, and because of this, you should consider getting a detox on patients who you think are having an abruption. Smoking also negatively affects the vascular integrity of the lining of the uterus, so this may also increase the risk of abruption. Hypertension is another significant risk factor. Whether it's from chronic hypertension, gestational hypertension, or preeclampsia, these patients have about a 5 times increased risk of abruption compared to normal tensive patients. Uterine anomalies such as fibroids could potentially also reduce the site strength of placental implantation, and this is another risk factor for abruption as well. But in your test, if you see any of these, abdominal trauma, cocaine, and especially hypertension, these should be big red flags for possible abruption if the patient is having vaginal bleeding. So how do these abruption patients present? They'll present with vaginal bleeding. The amount of bleeding can vary from clinically insignificant to a hemorrhage, and in some cases they may not have any visible bleeding at all. I'll go into that shortly. Because this is coming from the decidual layer, the bleeding is maternal in source. This is painful. Painful versus painless is a very good way of differentiating some of these conditions, so it's important to know that abruptions typically are painful, and it's either abdominal pain, typically if the placenta is anterior, or it could be back pain if it's more posterior placenta. This is why you're doing abdominal exams to see if there's any tenderness or if there's a hypertonic or contracting uterus. Sometimes, based on the contraction pattern, you may be a little bit more suspicious for a abruption because these patients have a irritable pattern. And what do I mean by irritable? So if we say that this top pattern here is normal, contractions every 3 minutes or so, the irritable pattern looks a little bit more like this. The frequency is much greater and the amplitude is usually a lot shorter. You don't always see this, but if you do see this, you should be a little bit more suspicious of a possible abruption. If there has been a very significant amount of bleeding, this could potentially lead to DIC and then ultimately shock as the patient becomes hypotensive. And if the mom is significantly anemic or in shock, then not enough blood will be going to the placenta. This will lead to a non-reassuring fetal heart tracing, and if left untreated, it could lead to an intrauterine fetal demise. If there is a significant amount of blood, on ultrasound, you may see a retroplacental hematoma, or a collection of blood behind the placenta and in front of the myometrium. You don't always see this, and in fact, the sensitivity can be as low as 25% to 60%. Remember that I said sometimes you may not have any bleeding. This is because the location of the separation can affect how much blood is visible. In a concealed abruption, the separation occurs somewhere in the middle of the placenta, and because of this, there is no path for the blood to escape from between the placenta and the myometrium, and the blood just accumulates between the myometrium and the placenta. Because of the location, the patient will not experience any visible bleeding. However, she is still losing blood, so she is still at risk for the other symptoms, including pain, irritability, DIC, shock, non-reassuring fetal heart tracing, and potentially IUFD. The other case is with a revealed, also sometimes called apparent bleed. So in this instance, the bleed is more peripheral, and this allows the bleeding to escape from placenta and go into the uterine cavity and ultimately through the cervix and into the vagina. This is actually a better kind of bleed because it causes the patient to realize she's bleeding, seek out care sooner, and potentially get an intervention. The general principles I mentioned for managing vaginal bleeding at the beginning of this lecture apply here, but I just want to point out a few subtle changes. You still want to get vitals, make sure the mom and the fetuses are okay. Abdominal exam and ultrasound. Ultrasound may show a hematoma behind the placenta, but this is not always there. Because this patient does not have a previa, it's okay to do a digital exam to see if she's dilated. You want to get your normal labs, and then you could also potentially get a detox if you're suspicious for abruption because cocaine is a source of abruption. And in terms of managing how you treat them, if they're preterm and stable, you could also give tocolytics or medication to help stop contractions, hoping that this may give additional time for the magnesium and the steroids to kick in. And because an abruption is not a contraindication to vaginal delivery, if they're term and stable, you can consider doing a vaginal induction as long as there's no other contraindications. Now let's move on to our next condition, placenta previa. In a placenta previa, the placenta is either partially or completely covering the internal os. The internal os is right here. This is the inner opening of the cervical canal, as opposed to the external os, which is what you see when you do a speculum exam. So if the placenta is touching the internal os, either just partially or completely covering it, that is called a placenta previa. A low-lying placenta is when the placenta is near the internal os, but not touching it. So if it's within 2 centimeters of the internal os, but again, it's not touching it, then this is considered a low-lying placenta. In some of your older textbooks, you may see a partial and marginal placenta previa, but these terms are no longer used, so don't worry about learning these. Remember, placental abruption is the most common cause of abnormal third trimester bleeding, and this is followed by placenta previa, which is the second most common cause, and it covers about 20% of abnormal third trimester bleeding. Here's another picture to help differentiate between a placenta previa and a low-lying placenta. So the placenta previa, the placenta is touching the internal os. But with a low-lying placenta, the placenta's edge is within at least 2 centimeters of the internal os, but it is not touching it. The risk factors for placenta previa and a low-lying placenta are the same. Remember, this is OB, so a history of prior condition is a risk factor for that condition, so a history of a previous placenta previa increases the risk of another placenta previa. Previous C-section or any other uterine surgeries increase the risk of a previa. The thought is there's scars within the uterus that may prevent the normal placental migration from the inferior pole to the fundus. Multiple gestations, so twins, triplets, or higher orders, can increase the risk of placenta previa, and you could think of it this way. There's more placentas, less real estate, so you may have some placenta already taking that ideal fundal spot, and then the other ones are stuck near the lower uterine segment and by the cervix. These are the 3 main risk factors that you should definitely know. Other risk factors include increasing parity, so having more children in general, increasing maternal age. Infertility treatment is an interesting one. You could think of it this way. Normally, when an egg is fertilized by a sperm, this occurs in a fallopian tube. But with IVF, if someone's implanting a pre-fertilized embryo, this is done via the cervix, and ideally they try to place it by the fundus, but because this is coming through the cervix, potentially this may implant lower down in the uterus. Another risk factor is maternal smoking and cocaine use. But remember, if you see cocaine, you should be really thinking abruption, but it is still possible for them to have a previa. But again, remember, the ones you definitely should know are these top 3 here. Fortunately, most placenta previas are diagnosed early in pregnancy before there's any kind of bleeding. Typically, it's diagnosed at the anatomic ultrasound, which is done halfway or about 20 weeks gestational age in the pregnancy. Typically, a transabdominal ultrasound is the first ultrasound that's done, and this is a good initial screen, but a transvaginal ultrasound is more accurate. Especially when you're trying to measure how far away the placental edge is from the internal os, transvaginal ultrasound is definitely the way to go. And even though it's going in the vagina, this is a safe ultrasound because you're not penetrating the cervix and touching the placenta. The key main difference that you tell these patients are absolutely they must have pelvic rest, either until they deliver or if they repeat the ultrasound and they see the previa has resolved on its own. So no digital exams, no checking patients if they're in labor, if they have a known previa, or if you're not sure where the placenta is located. No intercourse. And not only is it no intercourse, any activity that can lead to orgasm. I have actually seen one patient who was told to have no intercourse, but they weren't told the second part about no orgasms, and one thing led to another, and they came in with a heavy bleed and had to be delivered prematurely. Remember, speculum exams are okay, and so are transvaginal ultrasounds, so don't be afraid to use these if someone comes in with bleeding. And if you know someone has a previa, you should also evaluate for something called a placenta accreta. We'll talk more about this diagnosis later on, but if someone has had one C-section and they also have placenta previa, they have a 3% risk of having accreta. If they've had 2 C-sections, that's 11%, 3 is 40, then 61, and 5 C-sections and a placenta previa puts someone at a 67% risk of also having an accreta at the same time. As a med student, you should not try to memorize these numbers. The other good news about previas is a majority of them will self-resolve, especially if they were diagnosed early or before 20 weeks gestational age. The reason they self-resolve is because the lower uterine segment actually increases in size. It goes from about half a centimeter at 20 weeks to about 5 centimeters at term. So this can give you additional 5 centimeters of space. In addition to this, there's also a progressive directional migration of the placenta towards the fundus. So these two combined will help resolve a lot of previas and allow people to proceed with vaginal deliveries. So if you do see a previa at your anatomic, the next step is to repeat an ultrasound, and usually we do that at about 32 weeks. If the placenta is more than 2 centimeters away from the internal os, then this is considered normal, and you don't need any more follow-up. You could just treat them like any other patient. If it's still less than 2 centimeters away from the internal os, then repeat again at 36 weeks. If your ultrasound at 36 weeks shows a persistent previa, then you should have a scheduled C-section between 36 and 0 to 37 and 6. The reason we schedule them so early is because you don't want them to go into spontaneous labor, because this could lead to bleeding, causing maternal stress and fetal stress. If there's no previa, but it's still low-lying, so less than 2 centimeters, you can consider trying to do a vaginal delivery, or you could proceed with C-section. This is one of those things where you discuss the risks and benefits with the patient to help them choose the best delivery mode for them. As a med student, don't remember 32 or 36 weeks, just remember if someone has a placenta previa, you repeat the ultrasound to see if it resolves. If it doesn't resolve, you do a C-section, around 37 weeks. And if they just have a low-lying placenta, then you could consider either a trial of labor or a C-section. A placenta previa that comes in with bleeding usually has the following presentation. There may or may not be some sort of inciting event followed by vaginal bleeding. So this inciting event could be either the beginning of labor, so contractions. It could be rupture of membranes, or if she broke her water. There could have been something inside the vagina, postcoital. And the vaginal bleeding is maternal blood. The amount of bleeding can range as well. It could be clinically insignificant, or it could be a hemorrhage. And this is painless bleeding. So compare that to a abruption, which is painful. The placenta previa and also the Vasa previa are both painless. Another interesting thing to note is look at the direction of this baby. Instead of being directly head down, this is more oblique, almost transverse. People with a placenta previa or low-lying placenta are less likely to be vertex. The reason for that is because normally the head would want to engage down here in the lower uterine segment, but the placenta is blocking this. So oftentimes these patients will have babies that have malpresentation or are not vertex. The general management mentioned at the beginning also applies to a bleeding previa. The two main differences are, do not do a digital exam. If you learn one thing from this lecture is no digital exams on patients who have previas or patients who may have a previa and have not been ruled out yet. On your exam, you'll probably be asked some sort of question where someone presents with third trimester bleeding, and they'll ask you, what's the next best step? There'll definitely be one wrong answer that says, do an exam. That is incorrect. Most likely the correct answer they'll want you to choose is do an ultrasound, which will allow you to rule out previa or rule it in. So remember, no digital exams on potential previas. The other thing is the preterm and term management differs slightly because we can schedule C-sections as early as 36 weeks. If someone presents with bleeding at 36 weeks in a previa, you're not going to wait until they're technically term, which is 37 and over. And also, a previa is a contraindication to a vaginal delivery. So if someone has a previa, they have to do a C-section. If they do have a low-lying placenta, which is a placenta that's less than 2 centimeters from the internal os, but not touching the internal os, then you could potentially consider a trial of labor. Now we'll discuss Vasa previa. But before we discuss that in further detail, let me tell you what a Velamentous cord insertion is. A Velamentous umbilical cord insertion is when a portion of the umbilical cord, which contains umbilical vessels, is not protected. By this I mean there are membranes around these vessels, but it's lacking in Wharton's jelly, which is a protective cushion that normally surrounds these vessels. And this segment of the unprotected cord is by the end that attaches to the placenta. A Vasa previa is when there's unprotected fetal blood vessels that are less than 2 centimeters from the internal cervical os. Remember, less than 2 centimeters is also the same criteria for a low-lying placenta. A type 1 Vasa previa is when the unprotected fetal blood vessels are from a Velamentous umbilical cord. And for a type 2, the unprotected vessels are actually vessels that are connecting two separate parts of a placenta. These figures here should help clarify what the differences are. So starting from the left, we see a Velamentous cord insertion here where you have unprotected fetal vessels attaching to the placenta. Because these vessels don't have that protective layer of Wharton's jelly, you can imagine that they could be exposed and either be pinched off or compressed, or if a lot of traction is applied, they could potentially easily tear and cause bleeding. In the middle, we see a Vasa previa type 1. We have another Velamentous cord insertion, but the main difference here is that the unprotected vessels are within 2 centimeters of the internal cervical os. And on the right, we have a Vasa previa type 2, where again, there's unprotected vessels within 2 centimeters of the internal cervical os. But what differentiates this from the middle picture is that these vessels are connecting one placenta to a second placenta. For the Vasa previas, because they're located so close to the internal os, if this patient starts to dilate, or if they rupture their membranes, these patients are at very high risk of having severe bleeding from these unprotected fetal vessels, which could lead to rapid fetal anemia and even death. The two main risk factors for a Vasa previa include in vitro fertilization, or having twins, triplets, or higher order gestations. Remember, these are also risk factors for placenta previa. There are also some ultrasound findings that can make you a little bit more suspicious about the risk of having a Vasa previa. If you see an umbilical cord insertion in the lower part of the uterus, or if you see a placenta previa or a low-lying placenta, these should make you a little bit more suspicious of potentially having a Vasa previa as well. A subcenteriate lobe or a bilobe placenta are also things that should make you suspicious. A subcenteriate lobe is when you have one main placenta and then you have a smaller accessory placenta that are attached with blood vessels. A bilobe placenta is very similar, except in this case, both placentas are about the same size. Similarly to a placenta previa, most of these are diagnosed antenally by ultrasound before there is any bleeding. One of the findings on ultrasound is if you do a color Doppler flow, you'll actually see the blood flow of the umbilical arteries and veins right by the cervix. Because bleeding from a Vasa previa is so rapid and could be fatal very quickly, management for this condition is very conservative. You can consider giving steroids for fetal lung maturity as early as 28 to 32 weeks. Don't remember the exact weeks, just remember that you could give the steroids earlier because you want them to be on board because there's a high chance of a potential preterm delivery. And since fetal death can occur within 2 or 3 minutes of bleeding, you oftentimes will hospitalize these patients very early, around 30 to 34 weeks. Because if they have bleeding at home, most patients will not have time to get to the hospital before it's too late. And again, because of all these high risks of quick bleeding and death, you do a C-section much earlier, as early as 34 weeks up to 37 and 0. This is all in the hopes of delivering the baby before the patient goes into labor, because labor, or especially rupture of membranes, can lead to rapid bleeding and death. Just to clarify, this is only for a Vasa previa. If the patient only has a Velamentous cord insertion without a Vasa previa, you do not need to do these conservative measures here. If someone presents with bleeding in the setting of Vasa previa, this can be a very chaotic presentation. Typically what happens is there's some sort of inciting event, whether it's labor or rupture of membranes, and then there's vaginal bleeding. Usually this is brisk, bright red vaginal bleeding. This is painless bleeding. Remember, placental abruption is painful, placenta previa is painless, and vasa previa is also painless. And the source of the blood is fetal blood. Usually it's coming straight from the umbilical artery. And because it's coming straight from the umbilical artery, or the main source for the fetus, this is basically like if you had your aorta or your inferior vena cava cut in half. You get rapid exsanguination and an IUFD or intrauterine fetal demise within minutes. You don't have time to do a full NST, which is 20 minutes. Usually what you do is you only get a quick doptone just to make sure that the heart rate is still present in the fetus. If you were monitoring the fetus during the bleeding, what you'd see is bradycardia, or the heart rate getting less than 110 beats per minute, and then eventually you get to a sinusoidal rhythm, which is a sign of fetal anemia. And then as soon as possible, the next step is to proceed with a crash C-section, as long as the fetus is viable. So remember, viability is greater than 23 weeks. Because of how quickly you want to get to the C-section, patients who are admitted with a stable vasa previa are usually put in the room closest to the OR, because really few seconds can make a difference in whether that fetus survives or not. The fourth condition associated with significant third trimester bleeding is uterine rupture. A rupture is a complete disruption of all the layers of the uterus. So this includes the decidua, the myometrium or the muscle, and the serosa, the outer layer. This is very clinically significant and it's an obstetric emergency. You'll see non-reaching fetal heart racing, abdominal pain, and usually this requires an urgent or even emergent cesarean section. A dehiscence is similar to a rupture, but it may not go through all the layers, and usually it's not as significant. Oftentimes we'll see a dehiscence only when you're doing your C-section for another reason, and then you'll say, oh, look at that, there's a small opening in the uterus. You may have never noticed it if that patient never required a C-section. In the picture over here, you can see this is a complete rupture. The entire layers are broken, and the baby is actually leaving the uterus, but not through the cervix, but instead exiting into the abdominal cavity. Let's discuss risk factors. So again, history of prior condition is a risk factor for that condition. So a history of a prior uterine rupture is a risk factor for another uterine rupture. The other main risk factor is a prior uterine incision. The incision type classically associated with uterine rupture is a classical cesarean section. So if this is your uterus over here, usually what we do is a low transverse cesarean section where the incision is down here on the lower uterine segment. But with a classical cesarean section, a vertical incision is done, which starts off near the fundus and goes down towards the lower uterine segment. A classical cesarean section increases the risk of a uterine rupture so much that these patients are not allowed to labor after a classical C-section. A myomectomy, or removal of fibroid, also puts a patient at increased risk of rupture, especially if during the myomectomy the incision was deep enough to enter the inside of the uterine cavity. In other words, if the surgery required an incision that went all the way down to the endometrium, this is another high risk factor for a possible uterine rupture. And depending on the exact size or extent of the surgery, you may tell your patient that they should not labor if they had a prior myomectomy as well. Even though low transverse cesarean sections are safer, there's still increased risk of uterine rupture compared to someone who's never had any cesarean section. If someone's only had one C-section, the risk of uterine rupture is less than 1%. If someone's had two or more, the risk of rupture can be as high as almost 4%. Because of this elevated risk, patients who've had a low transverse cesarean section, which is abbreviated LTCS, can still labor vaginally, but only after discussion of the potential risks and benefits. If they've only had one, that's okay. If they've had two, it's still acceptable to labor, but most people will not allow anyone to labor with 3 or more C-sections. If someone's being induced for a vaginal delivery, they're at slightly increased risk of uterine rupture, especially if they've previously had a low transverse cesarean section. Because of this, prostaglandins, such as misoprostol, are not allowed if you've had a prior cesarean section. You are allowed to use oxytocin or pitocin, but there is still a slight increased risk of uterine rupture. And the last risk factor I want to talk about is labor. So being in labor with a prior cesarean section or uterine scar increases risk of rupture. That being said, it is possible to have a rupture even when you're not laboring, but typically most ruptures occur in the setting of contractions and labor. The reason we get so concerned about uterine rupture and tell patients that they shouldn't have a vaginal delivery is because it's both dangerous for the fetus and for the mom. The most common symptom of a uterine rupture, this is important to know because it's likely you'll be asked what the most common symptom is and get presented a few of these ones. But even though some seem more obvious of a rupture, a non-reassuring creasing is the most common symptom. This is painful. So remember, rupture and abruption are painful, previas are painless. And it's easy to remember that's painful because a muscle is literally being torn in half. You may or may not have vaginal bleeding. Remember, the tearing is occurring in the myometrium, so some of that bleeding may be entering the abdomen and be concealed. But because it's a myometrium, the source of bleeding is maternal. The factor that's unique for rupture, though, is loss of station. So as the uterus is tearing, the baby will no longer be forced down into the pelvis, and instead the contractions may be pushed up into the abdomen. As the fetus moves away from the pelvis, the station, or how low the fetus is in the pelvis, will decrease. If the fetus goes up high enough, it may enter the abdomen, and sometimes you could actually feel fetal parts such as a hand or a foot or a head on the abdominal exam. With a significant rupture and lots of bleeding, mom will also experience hemodynamic instability. So remember, this is dangerous both for the fetus and for the mom, and that's why an urgent or even emergency C-section is the next step. Another interesting thing is sometimes you may see a change in the contraction pattern. So if this was a pattern before, you may see something where the contractions can space out. You may see them get closer together. You may see a laddering where they get stronger or they get weaker. But the most common presenting symptom is a non-reassuring fetal heart racing. So if you're on labor and delivery and you start to see a fetal heart racing that's getting worse and worse in the setting of a prior C-section, you should start to be very suspicious for a possible uterine rupture. If that's the case, the next step is urgent or emergent delivery, and this is via cesarean section. You deliver the baby as soon as possible, and then afterwards you look at the uterus to see if you could either repair it or if you have to do a complete hysterectomy. If possible, repairing the uterus is always preferred for two reasons. First, you get to conserve future fertility, and second, even if the patient did not want to have any more children, a hysterectomy at the time of a C-section is a much more complicated procedure associated with much more bleeding, morbidity, and mortality. So if possible, we always try to repair the area of rupture instead of proceeding with hysterectomy. But if the rupture is too big or the bleeding is uncontrollable, then we have to do a hysterectomy. After this pregnancy is completed, you should also counsel the patient that all future pregnancies must have a C-section, and instead of doing them like you normally do at 39 weeks, you can do them earlier, either between 36 and 0 to 37 and 0 weeks. The goal of doing it early is to do the C-section and delivery before the patient goes into spontaneous labor to help reduce the risk of another uterine rupture. Now let's do a quick review and summary of these 4 conditions. When starting your differential, the easiest thing to look at is whether or not there is pain. A previa, whether Vasa previa or Placenta previa, will be painless. The other 2 will be painful. But keep in mind, if someone has a strong epidural, this may mask the symptoms of pain. The only one that has fetal bleeding is the Vasa previa, because that bleeding is coming straight from the umbilical artery. If in your question stem you see something like trauma, for example, car accident, cocaine use, or hypertensive disorder, you should really think about abruption. If someone presents with bleeding and has had no prior prenatal care, you should think about previas, more likely a placenta previa because that's more common, but it could also be a Vasa previa. Especially if they've had prior uterine surgery, which puts you at increased risk of a previa. If there's severe distress and bright red blood, then that should make you think more invasive previa as opposed to placenta previa. And then if you see someone in labor and if they had a prior C-section, you remember the most common symptom is non-reassuring fetal heart racing, but that's not really unique. But the unique symptom is loss of station. And these should make you think about uterine rupture. In terms of mode of delivery, abruption is really the only one where you can have a vaginal delivery, as long as the patient is stable. If you have a low-lying placenta, you could also consider a vaginal delivery, but basically you should think vaginal delivery with abruption, and everything else requires a C-section. So those were 4 main causes of abnormal bleeding in the 3rd trimester. The placenta accreta spectrum doesn't really cause abnormal bleeding, but because we're talking about all these other placental disorders, now is a good time to review this condition as well. Normally, the placental villi will attach to the decidua basalis. Remember, this is the endometrium that's changed for pregnancy to support the placenta. In the placenta accreta spectrum, the placenta becomes abnormally attached and is adherent to the uterus. There are 3 subcategories. A placenta accreta is attached right to the edge of the myometrium. Here you could see it goes past the decidua and attaches to the myometrium here. With an increta, it will invade the myometrium, so it goes down deeper into the myometrial layers. And then with a percreta, it penetrates through the myometrium, so it goes past the myometrium into the serosa and potentially further. Depending on the exact location of the placenta, for example, if you have an anterior placenta, it can invade surrounding structures such as the bladder. The way to help memorize these different types is accreta with A attaches, increta with an I invades, and percreta with a P penetrates. Things that put a patient at increased risk of having an accreta are having a history of a C-section, advanced maternal age, prior uterine surgery, or a DNC or curettage, or Asherman syndrome. Remember, Asherman syndrome is a condition when there is adhesions in the endometrial lining, oftentimes caused by an aggressive DNC in the postpartum setting, but can also be due to other etiologies as well. The main common thing for these conditions are adhesions or abnormalities in the endometrium. Somehow this can lead to an issue with implantation of the placental site, causing a deeper invasion past the decidua, making the placenta much more adherent than it should normally be. Fortunately, a placenta accreta, similar to a placenta previa, can be seen on ultrasound. There's 2 ultrasound findings I want you to memorize for your test. The first one is a placenta previa. Remember, I mentioned this earlier, having a placenta previa puts you at increased risk of having an accreta, and about 80% of patients who have an accreta also have a previa. This risk increases with number of C-sections, so 1 C-section puts you at 3% risk, 2 puts you at 11% risk, 40, 61, and almost 70. Don't memorize any of these percentages. Just know that a placenta previa puts you at increased risk of having an accreta, so you should be more suspicious. So that's the first one I want you to memorize. The next one I want you to memorize is multiple vascular lacunae, often described as moth-eaten. So if there's multiple vascular lacunae in the placenta, that is a sign that's very suspicious for a possible accreta. The other things I'll just mention, but you don't have to spend too much time trying to learn these, are loss of normal hypoechoic zone between the placenta and the myometrium. So remember, that's where the decidua normally is. But with a placenta accreta, the placenta has passed through that point, so there's no decidua, and that's why you lose this hypoechoic zone. There is decreased myometrial thickness behind the placenta. And the reason there's decreased thickness is because that space is being taken up by placenta now. If this is a percreta, you may also see abnormalities between the uterine serosa and the bladder interface. So this is a sign concerning for possible invasion of the bladder. And of course, if you directly see the extension of the placenta into the bladder, that is a very obvious sign that you have a placenta accreta, or in this case, a percreta. Ultrasound is the diagnostic image of choice, but in this case, if you have an uncertain diagnosis, an MRI may be useful in helping to rule in or rule out the diagnosis. Another interesting fact is sometimes you'll see abnormal lab markers, especially the ones you use on a quad screen. For example, you may see an elevated AFP. But this, as an isolated finding, is not a way to diagnose placenta accreta. It should just make you a little bit more suspicious if you see it along with these other findings here. Besides those abnormal ultrasound findings, a patient with a placenta accreta is basically asymptomatic until after they deliver the fetus. So whether they have a vaginal delivery or a C-section, what would happen is after delivery of the fetus, when it's time for the placenta to detach, you are unable to deliver the placenta. And this is again because it's too adherent or attached to the myometrium. If you apply too much traction to the placenta, you may get a uterine inversion where the uterus will literally invert, almost like you're pulling a tube sock in from the inside, and this itself can increase risk of a hemorrhage. But even if the uterus does not invert, if a placenta remains attached too long after delivery, this can also cause a hemorrhage. So what must be done is if the patient had a vaginal delivery, you must perform an emergent laparotomy to remove the placenta. And because the placenta is so adhered to the uterus, typically the placenta and uterus are removed together by doing a hysterectomy. And this is why it's important to diagnose this condition before delivery, because if you knew that the patient had an accreta, they should not be doing a vaginal delivery. Instead, in order to reduce the risk of a postpartum hemorrhage and a possible unscheduled emergent surgery, what you should do is you should schedule a C-section at 34 to 35 and 6 weeks. And not only are you scheduling a C-section, you're scheduling a planned cesarean hysterectomy. So you know going in, most likely you're going to also remove the uterus. And we do it so early, 34 to 35 and 6, because we want to deliver the patient before they go into spontaneous labor to prevent a possible postpartum hemorrhage and unscheduled emergent surgery. The way you do this procedure is you do a C-section like normal, and you could check to see if the placenta will come off by itself. Ultrasound is a good way of diagnosing it, but it's not 100% accurate, so there's always a small chance the placenta could detach normally and you won't have to do a hysterectomy. But if it does not, then at that time, you proceed with a cesarean hysterectomy. Because you know you're delivering this patient prematurely, you could give them steroids for fetal lung maturity. And because cesarean hysterectomies can be so morbid, especially in the setting of a percreta with invasion of the bladder or other surrounding structures, it's important to have a multidisciplinary team and surgical backup. So GYN-onc is typically called in because they're such great pelvic surgeons, but also urogyn or urology in general and gen surg may be helpful to have as backup in case you need an extra hand. If a patient strongly desires fertility preservation, you can try to leave the uterus in place. The downside about this is about 20 to 40% of patients will not tolerate this and end up having a postpartum hemorrhage, requiring them to go back to the operating room and have an additional surgery. That being said, a patient's desire for future fertility is very understandable, so after a careful discussion with the patient, and if they understand the risks and benefits, you may try to avoid a cesarean hysterectomy, but understanding that there's a high chance they may need additional procedures after their C-section. In this last slide, we're going to talk about Rhogam. This is an important slide, and it's likely you may get one question from this slide alone. So Rhogam is a medication that we give to mothers who are Rh negative. In other words, A negative, B negative, or O negative. And the reason we give it is to prevent the mother from developing maternal antibodies against fetal red blood cells. Routinely what we do is we give it 2 times, once at 28 weeks gestational age and then 1 time postpartum. But if a patient has bleeding before they deliver, usually we give them another dose of Rhogam at that time, again only if they're Rh negative. So what happens if we forget to give a patient Rhogam? The mom will develop anti-Rh antibodies. If you remember from your immunology class, the first thing that develops is IgM. But IgM does not cross the placenta. Because of this, that current pregnancy will not be affected by these antibodies. But after that pregnancy is done, those cells will start to develop IgG antibodies, and these can cross the placenta. So IgM is too big and cannot cross placenta, but IgG can. So in her next pregnancy, those IgG antibodies will cross the placenta and attack fetal red blood cells. This will cause anemia and hemolytic disease. If it's severe anemia, it can cause high drops, which can be fatal. But keep in mind, these antibodies will only attack the fetal red blood cells if there are Rh-positive antigens on the fetal red blood cells. And since mom is Rh negative, the only way that a fetus will have Rh-positive antibodies is if the father of the baby is also Rh positive. So if you know for sure that the father is Rh negative, you don't have to worry in that particular scenario. That being said, sometimes people don't know who the father is, or they may have a different partner in the future, so it's always important that if a patient is Rh negative, to remember to give them Rhogam. Routinely we give that 28 weeks and postpartum, but if someone has antenatal bleeding, for example from an abruption, you should give them Rhogam again if they are Rh negative. If I catch any mistakes, I'll try to include them here on my slides. And if you're interested in additional reading, check out the Obstetric Care Consensus on the Placenta accreta spectrum or a practice bulletin on RHD allo immunization. Thank you for listening and have a wonderful day.